my topic is very short, and in continuation to what Dr. Deepti taught us today, I'm just going to tell you a little bit about mainly the differences between polycystic ovarian syndrome and late onset congenital adrenal hyperplasia, how to suspect and differentiate. This is the topic given to me, and I thought it was a brilliant topic because I have very little to say, and number two, I got a good opportunity to read all of this again. I hope it changes. Right. Why is the dilemma to differentiate PCOS and non-classic congenital adrenal hyperplasia, which is also known as late onset congenital adrenal hyperplasia? The clinical features of PCOS and non-classic CAH are hirsutism, ovulatory and menstrual dysfunction, and therefore differentiation between these two syndromes is difficult based on clinical grounds only. So both are associated with obesity, insulin resistance, dyslipidemia. Both are hyperandrogenic disorders. Both may have polycystic ovarian morphology, and both may present with ovulatory subfertility. So is PCOS the difficult one to diagnose? Yes, I think it is the most difficult to diagnose, even though it is so common, because it is by the diagnosis of exclusion. It is confirmed once other disorders that mimic it have been excluded, such as we just count them on our fingers. Hyperprolactinemia, you do prolactin levels as many times and you can rule it out. Thyroid disorders, then comes non-classic congenital adrenal hyperplasia, which is closest to PCOS, and of course androgen producing neoplasm. So these four are the important ones, out of which non-classic congenital adrenal hyperplasia takes the forefront in the differential diagnosis. So a little bit about PCOS. You've just heard about all the criteria of diagnosing PCOS. I'm just taking you across the literature in these two slides. It was once upon a time known as sclerocystic ovaries way back in the 1844 and 1895. And they thought it was cystic oophorytis also. Then polycystic ovarian disease was first described by Steen and Leventhal in 1935. We all know 7 cases of infertility where they did wedge resections, and they described the whole syndrome. Then it came as syndrome O of ovarian confusion. It likely refers to polycystic ovarian syndrome, a common hormonal disorder affecting women of reproductive age characterized by irregular periods, excess androgens, and polycystic ovary. So, it went on evolving till we got the criteria, which was first laid in 1990 by NICHD and NIH together. And what did they say? That we need to symptoms: hyperandrogenism, clinical or biochemical, which is high serum androgen concentrations, and you have to know what is normal for your laboratory to know whether it is high or not. And number 2, there is menstrual irregularity and or chronic anovulation or oligomenorrhea. Both need to be met. Then came the Rotterdam Consensus in 2003, and that said there are 3 clinical criteria. One is hyperandrogenism, clinical or biochemical. 2 is menstrual irregularity, and 3rd is the appearance of polycystic ovaries on ultrasound. And 2 out of 3 need to be met here. Then came the Androgen Excess PCOS Society 2006, and they said hyperandrogenism and hirsutism or hyperandrogenemia is a must. And with that, we could have ovarian dysfunction in the form of either ovulatory dysfunction or a polycystic appearance of ovaries. But then in 2023, the PCOS International Consensus endorsed Rotterdam criteria as the most standard criteria to be followed to diagnose PCOS. Having said that, I'm just bringing you one Indian slide, Dr. Tripathi, which was published in the European Journal 2018, which said that all the 4, Dr. Deepti told you that there could be 4 types of different presentations, but the frank PCOS, which is more than 50% of cases present with, which have all the 3 features of hyperandrogenism, ovulatory dysfunction, and polycystic ovarian morphology. This is the most severe one, which is the least severe one, which has no hyperandrogenism. So hyperandrogenism is one feature which makes it severe in terms of happening of metabolic syndrome later in life. And the least common is the one where ovulation is happening very beautifully, yet you get a polycystic appearance in the ovary on ultrasound and hyperandrogenism. So having said that, PCOS is a spectrum. It could be as little as this point over here, where you see nothing, just a tip, that you stimulate the ovaries and you find a PCOS appearance. Believe me, in even hypo patients, hypogonadotropic, hypogonadotropin patients, I have stimulated them, and eventually what I got was a PCOS like response. Like 10 follicles emerged at the end. And then I went into literature and I found that it has been described even in women who present with hypogonadotropic hypogonadism. And only when you stimulate, you get to know that there is underlying PCOS also in these women. And on the maximum side of the spectrum, you may find everything, which is hyperandrogenemia, hyperinsulinemia, increased LH, which generally happens in only 30% of patients, hyperprolactinemia, which is associated only in 5% of patients, and ultrasound evidence. So this is a disease of spectrum, which can start from a minuscule to a huge presentation of PCOS, and hence the difficulty in diagnosis. So I thought, let me bring out common and different characteristics of the two syndromes, um, which is the congenital adrenal non-classic hyperplasia and PCOS. Look at it. NC-CAH is a rare syndrome. PCOS is common. So once a girl comes with these features, hyperandrogenism and features of hyperandrogenism and polycystic ovaries or anovulation, menstrual irregularity, diagnose her as PCOS till you've ruled out the late onset CAH. So it is very rare. How rare is it? In 1,000 you will get one patient, or in 5,000 you will have one patient. Whereas in PCOS, you have it as 4 to 6% in reproductive age group women. Out of every 100 women, 6 will be having PCOS. Whereas out of every 1,000 women, 1 would be having CAH. In hyperandrogenic women, if you can classify and put all the hyperandrogenic to one side, then you'll find 1 in 100 having CAH, 50 to 80% will have PCOS. So pathophysiology, we all know, it is defective enzymatic activity in congenital adrenal hyperplasia, whereas PCOS has a multifactorial underlying factors like genetic and environmental factors. Now we look at hyperandrogenemia manifestations. Both have common hirsutism, acne, but the only important thing is that clinical hirsutism with aging either remains similar or increase in the CAH group, whereas in PCOS, it will become milder with age. As age advances, the hirsutism becomes milder. Gynecological manifestations, well, menstrual irregularities, though they are much more common in PCOS, but they happen in both. In CAH, polycystic ovaries, infertility, menstrual irregularities, and pregnancy complications. And the most common pregnancy complication, I'm not talking about the underlying metabolic syndrome in both these conditions, which will lead to hypertension, diabetes, and other problems. The most important pregnancy complication is first trimester spontaneous abortions, which possibly can be sorted out in the CAH group, but not in the PCOS group so well. Then we come to other characteristics about metabolic syndrome. So again, type 2 diabetes is common in both, obesity is common in both, insulin resistance is common in both, and dyslipidemia is common in both. So in both the conditions, or whichever you've diagnosed at PCOS, you have to keep metabolic syndrome in the back of your mind. Mood disorders, depression is again common in both. Inheritance mechanism is absolutely different in both. It is autosomal recessive in congenital adrenal hyperplasia, Whereas in PCOS, we really don't know what is the mechanism to have it, though we do put hereditary to some extent into it, but there are multifactorial origins of this syndrome. Special tests for differential diagnosis is available in congenital adrenal hyperplasia. What do? You do basal 17 hydroxyprogesterone. If it is more than 2 nanograms, it will diagnose CAH in about 85 to 90% of cases, but even in 25% of PCOS, you will find it higher. So the specific hormonal diagnosis is the ACTH stimulated 17 hydroxyprogesterone. So you give ACTH and 17 hydroxyprogesterone jumps up. And this will happen in all patients with CAH, but in 0% patients with PCOS. What do we do? So how do we test for non-classic CAH? The diagnostic workup in non-classical CAH in older children and adulthood may include several blood tests like morning 17-hydroxyprogesterone levels, then the ACTH stimulation test, and last of all, the genetic testing. I'll talk about it in just about one slide to give you an overview of why this is important. So how do we test? 17-hydroxyprogesterone measurement, a baseline is done. And if it is more than 2 nanogram per ml, which is equivalent to 6 nanomoles per liter, it is a screening threshold for non-classic CAH. If the baseline is elevated but not definitely diagnostic, then we need to do a ACTH stimulation test. And for that, if the 17 hydroxyprogesterone level goes above 10, or even better if it goes above 15, which means 10 nanograms per ml or 1000 nanograms per milliliter. And for 15 nanograms, it's either 15 nanograms or 1500 nanograms per DL. After ACTH stimulation confirms the diagnosis of non-classical CAH. How do we perform? We will take one measurement at baseline, 8 to 9 o'clock. We take one blood sample, and then we inject 250 micrograms of synthetic ACTH co-syntropin. After we've injected, exactly after 1 hour, you'll take another sample and you'll find 17 hydroxyprogesterone has flown up in cases of CAH. It's gone above 10 or 15 nanograms. And the diagnosis is then and there confirmed, because in PCOS, this will never happen. However, there are now newer methods, and liquid chromatography tandem mass spectrometry is a very recent, more specific and sensitive method for measuring 17 hydroxyprogesterone levels, and now is being increasingly used for testing and screening of CAH. And the last is genetic testing of CYP21A2 genotyping. This is a monogenic disorder, which is recessive, can be used to confirm the diagnosis for pre-conception counseling, especially when 17 hydroxyprogesterone values are more than 10 nanograms per ml. So it's so important to know that genetic testing is important. Once upon a time, we used to say a woman is pregnant, oh, give her androgens, give her something to suppress the androgen. Nothing is required. This is an autosomal recessive disorder, and if it comes from one parent, it will never present as a major problem to the baby. So we don't need to bother what is the fetus sex and what can we give. So what is the approach to treatment? If you see, there are options for non-classic CAH where we use absolutely same things like in PCOS, that is OC pills. We tell them lifestyle modifications, we give them anti-androgens, and we give them clomiphene, letrozole, all type of ovulation-inducing agents. What is different in PCOS? Metformin is a very important drug. Whereas in CAH, glucocorticoids is a very important drug. So just remember, these are the two drugs which are different in these two groups regarding treatment. They are not a must. Metformin is not a must and glucocorticoid is not a must. But you know that if the diagnosis is correct, you may use glucocorticoids, especially where the patient is not tolerating OC pills or drugs like, OC pills for cycle management or for hirsutism. So OCPs and antiandrogens is primary therapy for hyperandrogenic symptoms in both these cases. You give OCPs alone with antiandrogen separately like spironolactone, or you combine it in the OCP as cyproterone acetate or drosperinone. It is up to you. OCPs are also given for menstrual cycle regulation in both more effectively. OCPs, if contraindicated because of metabolic syndrome or something which the child has, overweight, then a progestin pill or cyclical progestin can be used in both these cases. Like you were told that in adolescents also we like to use only progesterone, and norethistyrone is a very, very good potent progesterone which I use mostly in my practice of AUB, but not here. Here you can use pills which are very small doses of progesterone. Then glucocorticoid therapy is only used for non-classic CAH, for hirsutism and menstrual irregularity when OCPs or antiandrogens are not tolerated. But it is less effective in symptom management. You can start them on glucocorticoid, but dose even in slight excess may have potential side effects. Then exercise and diet improves metabolic parameters as well as reproductive function in both. Regular screening of cardiometabolic alterations with use of statins and anti-obesity drug, bariatric surgery, everything goes equally in both the cases. Metformin is again in PCOS. So I told you glucocorticoid in CAH and metformin in PCOS, especially if there's type 2 diabetes or impaired glucose tolerance who fail lifestyle modification. So lifestyle modification is the first advice. And then those who fail, you could go on to give them metformin. Pioglitazone is another drug which is very effectively used in women with PCOS, possibly protects from developing diabetes and cardiovascular problems, and then can be used very safely in women who are single, who are not looking at pregnancy, who are not desiring fertility. Inositols are second messengers for insulin, and when given to PCOS women can help metabolic, menstrual, ovulatory and hyperandrogenic symptoms. And like Dr. Sunita said, one can always try. It has to come into our books, into our guidelines, that we can use them safely for our patients. Having said that, fetal transmission has to be remembered, that since congenital adrenal hyperplasia is an autosomal disorder, both the mother and father must be carriers of CAH for a child to have congenital adrenal hyperplasia. So if a patient comes to you with CAH, please look into her mother-father genetic makeup and you will find the gene for both. Now, women with CAH, and that means classic CAH and non-classic CAH, do not transmit the disease to the offspring unless the partner is a carrier. So genotyping of the male partner may be done for genetic counseling. So very important, when you've diagnosed a woman with CAH, classic or non-classic, her husband needs to be tested genetically. And couples with the recessive CAH gene in both parents have an option to prevent CAH in their offspring through PGD and the use of IVF. So I always bring the use of IVF into my talks, that one can go for this because both are recessive disorders. Genotyping in non-classical CAH should be suggested in patients who seek fertility, because approximately, now look at this, these are very important figures which I just found yesterday when I was making this presentation, that 2/3 of the patient with non-classic 21 OHD carry a severe mutation. So 2/3 who have a severe mutation, the total risk of classic 21 OHD in an offspring of a patient with non-classic type is about 2.5%. That means all the non-classic females may have 2.5% of children with severe classical deficiency of 21 OHD, and risk of non-classic deficiencies as much as about 15%. So it's very important to do genotyping to know whether husband is carrying the same gene or not. So knowledge of the father's genotype can help assess these risks more precisely. Therefore, the distinction between PCOS and non-classic CAH is mandatory for genetic counseling on several aspects, including future generations. So in summary, asymptomatic non-pregnant women with PCOS or non-classic CAH, you don't give any treatment. both presenting with hyperandrogenism, managed with oral contraceptives and or antiandrogens. Both presenting with menstrual irregularities, managed with oral contraceptives. If OCP is not tolerated, then only in the non-classic COH, you can try glucocorticoids, but these are less effective. Infertile women with anovulatory infertility, you treat with oral ovulogens or gonadotropin, both. In non-classic CH, infertile women with ovulatory dysfunction can be treated with glucocorticoids, but if they don't ovulate on that, then treat with oral ovulogens and gonadotropins. History of miscarriage in non-classic CH can be treated effectively by adding glucocorticoids which don't cross the placenta. So the diagnosis of non-classic CH and PCOS, NC-CAH is a one-step diagnosis where you do a morning 17-hydroxyprogesterone, you can do a ACTH stimulation test, and to add on, you can just do a genetic testing and stamp the diagnosis on the patient, whereas PCOS is a diagnosis of exclusion. Thank you very much for a patient hearing.
Thank you, ma'am, for a very, very crisp and excellent talk. And as we all can see the last slide, PCOS is a diagnosis of exclusion, and we are writing PCOS every right, left, and center. So actually we need to exclude and then say that this is PCOS.
80% is PCOS. Out of 1,000, one will turn out to be CAH.
Right, but ma'am, then prolactin and thyroid and everything else is also to be ruled out.
Yeah.
So Brigadier Sharma sir for his expert comments, please.
No, I think Madam has covered the topic so well. There's nothing more to add to it. But yes, patient with hirsutism, whether PCOS and non-classical CH, all have more of a psychological thing, and we have to look at that aspect as well, besides the treatment we are giving to these patients.
Right, sir. Ma'am, I have a question. So all those girls whom we are suspecting to have PCOS, so universally you recommend 17-OHP should be done for all?
Yes, I do it for all my PCOS where I find that, there's no family history, or there is a family history also. Out of the test, I don't do DHEAS and testosterone levels. Apart from thyroid prolactin, I just do 17-hydroxyprogesterone in the hormonal profile. Rest of all, I do a OGTT and I do a lipid profile for these women. That's all.
Right, ma'am. So I think this is very, very important message that 17-OHP should be done to rule out initially only. And it is to be done
for all thyroid, and you see thyroid prolactin in all these girls. So just do a 17-hydroxyprogesterone. Apart from that, you can do a OGTT and a lipid profile, blood pressure monitoring, that's all.
And in follicular phase, right, ma'am? 17-OHP always should be done in follicular phase, early morning samples. Correct. So, Dr. Banda Sodi, ma'am, your comments, please.
Thank you, Abha ma'am, for such a crystal clear presentation. And what I would like to say here is that what the mind does not know, the eyes can't see. So here we have seen so many patients with hirsutism, but we never normally think about the non-classical CH. So I think all of us should get into our armamentarium about evaluating for this as well. And the same question which Dr. Sunita asked about including 17-hydroxyprogesterone was again hovering in my mind. So I think that should also be part of the testing that we do for these girls, so that we don't miss out on this entity which has a little different treatment of adding glucocorticoids. So otherwise,
it has a genetic implication on the child later on. So once we identify, we also look into the father's genetic. It's a monogenic disorder, can be identified very easily.
Yes.
Right. So Dr. Poonam Goyal is there. Dr. Poonam, Dr. Nisha.
Thank you, ma'am. Thank you. As usual, crisp and very, in brief, very detailed presentation. And I couldn't stop clicking the pictures. So no questions from my side. I have taken my notes. Thank you so much.
Hello, ma'am.
And it was wonderful, always listening to you. Thank you so much, ma'am.
Dr. Poonam Goyal is there.
Madam, can you please share your last 2 slides?
No, I've just stopped sharing. You take it from someone else has just taken. Bandana has taken all the pictures.
I have taken the pictures. I'll share in the group, ma'am.
Please.
Thank you so much.
Ma'am, just one
Dr.
question.
Poonam Goyal is there?
Glucocorticoids, what dose do we give?
I know this was coming, Shalini. See, one is that prednisolone is the drug of choice.
Yes.
Ideally, dexamethasone can be used, but it's not used very commonly. Either one uses cortisol or prednisolone. In pregnancy, these are the preferred drugs because they do not cross the placenta, or do they cross? Right?
Yes, ma'am. So,
Because
so
inactivated.
how long are they to be given? I mean, are they to be given then lifelong?
No. You see, nowadays management has totally changed. You don't even think of giving any dexamethasone in pregnancy unless the father is also a carrier of the gene. If the father is the carrier of the gene, then you try to know what is the sex of the baby. If it is a male child, nothing needs to be given. If it's a female child, then only you would think of giving something. And in that case, you would give something like hydrocortisone. It is favored because it mimics the natural cortisol hormone and is inactivated by the placental enzyme, preventing fetal exposure. So if you are giving it to a girl who's trying pregnancy, you use hydrocortisone or prednisolone so that if she accidentally becomes pregnant also, it doesn't go to the fetus because it doesn't cross the placenta. And once you know she's pregnant, there's no need to give any steroid, no corticosteroid to be given once she's pregnant.
No, otherwise, in young adolescent girl, for how long they can be given, ma'am?
As long
So,
as you if she's got very good symptom control, then you look at the 17-hydroxyprogesterone levels, see that they've come down, and the prednisolone 2.55 milligram, whatever you think is working for her. But please don't give it in excess because it has its own side effects for
Yeah.
young girls. So if you can
Especially
avoid giving a
exposure of
steroid,
the-
yeah. So if you can avoid giving in a non-classic case, there is no harm. Don't give. Only if they don't tolerate OCPs or anti-androgens, then corticosteroids are to be thought of in these patients. So at the outset, treat them like PCOS. Everything goes like PCOS.
and it's adult onset
Adult
usually.
onset.
So you don't need most of the times for any kind of symptoms. But once patient is coming to you and you start suspecting that it is not actually PCO but NC-CAH, and then if you feel patient needs steroids, then you can give. And as ma'am said, dexamethasone not to be given because it crosses placenta. We can use hydrocortisone or we can use prednisolone. But ma'am, as soon as patient becomes pregnant, we stop it.
You stop it. You don't have to give anything.
With someone who's not trying to get
Alright.
pregnant, then dexamethasone can be given.
I don't know.
Like
You'll have to find out. I have seen 2 cases of NC-CAH in my whole life. And that one girl, her husband also was genetically positive for it. And then she went away to Singapore and they told her, don't take anything, just let the pregnancy grow. And the pregnancy grew very well. She did not have to really take any steroid during her pregnancy. So steroids are not recommended anymore in pregnancy. Only if a woman gets accidentally pregnant who's not on OC pills and who's taking steroid and she's also looking at fertility, there we know that we'll give a steroid which will not cross the placenta and go to the fetus in case she becomes pregnant. But if she's being managed by oral ovulogens, then you don't need to do anything. Only if she's not on oral ovulogens and yet taking steroid and she's very nicely menstruating on steroid, she could get on them. I would prefer to give oral ovulogens rather than give steroids when she's attempting a pregnancy and her cycles are irregular.
Yeah, Dr. Sunita would request to kindly share the recording, please. Because
Yeah, it will. I think it is
one more
recorded all
time
the
before-
time, and all the more reason it is recorded this time very well because of our great speakers who have logged in, Dr. Abha ma'am, Dr. Deepti. So I'm 100% sure Malti will send the recording, and it's available online. In few days it will come. Don't worry for that. So I will want now Dr. Sharda Jain ma'am